Hello everybody, Dr. Carlo Oder, emergency physician and the founder of DrER.tv. If you're watching this video today, you are watching ED Exit Video Pro, our channel designed for the healthcare enthusiast, whether it be a medical student, paramedic student, nurse, paramedic, EMS, or even young doctors and doctors in general who want to learn and keep up to date with cases and interesting factoids of medicine. This is a clinical case. It is the case of a 10-month-old female infant who presented to the emergency department within 3 days of worsening rash, fussiness, and a 1 day of fever. She had previously been evaluated in the emergency department and given topical and oral steroids for the same rash, and it was not improved. Her medical history was significant for eczema. Physical examination revealed a temperature of 100.9 degrees Fahrenheit and a diffusely crusted ulcerated rash on an erythematous space with serpiginous appearance at the elbows. So this is what the rash looked like. You can see it. It was there on the face. You can see it there on the elbows. And obviously it had a history of eczema, which looks very much like that, but it's way more pronounced. This is an up-close picture of this rash, and you can see that the lesions are kind of getting together, like the little lines. All right, so let's get to it. What's the diagnosis? This is eczema herpeticum. Eczema herpeticum. This infant was admitted to the hospital for IV intravenous acyclovir and vancomycin, a presumed diagnosis of eczema herpeticum with bacterial superinfection. So this is why the patient needed both acyclovir, which is an antiviral medication, and vancomycin, which is an antibiotic. So the patient had initial herpetic skin lesion and also bacterial infection. The skin cultures grew herpes simplex type 1 and methicillin sensitive Staphylococcus aureus, which is very common skin type of infection. She received 48 hours intravenous medications and was discharged without a fever and receiving oral acyclovir and cephalexin, which is Keflex. So not all eczemas are the same. Eczema, yes, is treated with steroids, both oral and topical, but upon the patient's presentation with fever and salitis changes, and I think the true trick here is these lesions that are coming together in a herpetiform kind of pattern, and that should bring you to the clinical judgment or suspicion that this is a primary viral infection with bacterial superinfection, so it got Staph aureus on top of that, causing cellulitis and fever and so on. So this is a new one for me, eczema herpeticum. Of course, I know what eczema is. I know what herpes type lesions is, but the two together and how to treat it was a new one for me. So I hope you learned something watching the pictures, watching the clinical presentation. Hopefully you remember eczema herpeticum in your differential diagnosis of a rash with lesions that have that dendritic type pattern that you would see in the HSV in the eye and other areas. And the fact that you would admit this patient with oral antibiotics, yes, or IV antibiotics, but also acyclovir because it's a viral primary infection. And eczema herpeticum is also known as Kaposis varicella eruption, and is rare, but it can be life-threatening. And it's a secondary infection of atopic dermatitis. Most commonly affects immunocompromised patients and children with atopic dermatitis, especially those being treated with systemic steroids. The condition is indeed a dermatologic emergency and carries a mortality rate of 9% if untreated. Staphylococcal colonization has been reported up to 90% of patients because staph lives in the skin. It just finds that broken up skin and grows in that area, further increasing the risk of systemic infection. The diagnosis should be highly suspected if the clinical situation is one of vesicular rash with punch-out erosions and systemic symptoms such as fever in the setting of the patient with atopic dermatitis. Diagnostic confirmations is with that dreaded Zangsmeer we learn in microhistology or one of those classes we took in medical school, or viral culture from the lesions growing herpes type 1. This is not a sexually transmitted disease. This is HSV1, not HSV2. So Kaposi's varicilliform eruption, rare, life-threatening, complication of atopic dermatitis, mortality rate 9% if untreated. And one last look at that rash, so it kind of anchors in our mind, and hopefully one day when we see this together, we'll be like, hey, I learned that at ED Exit Video Pro, and we can treat our patients better. Hey, I hope you enjoyed this video and learned a lot. I certainly did. We'll see you in the next one. Bye-bye.